Good morning. Today I'm going to be presenting my research, which was a retrospective audit of a patient profile from a long-term epilepsy monitoring unit in Durban, South Africa. So long-term video EEG in a comprehensive epilepsy monitoring unit is imperative in the investigation and workup of patients with suspected epilepsy. The monitoring procedure involves continuous recording of ECG and EEG with simultaneous video 24 hours a day, with the intention of capturing both electrical and clinical events. The aim of video EEG in a long-term epilepsy monitoring unit is to determine whether seizures are epileptic or non-epileptic, where in the brain the seizures are occurring from, the clinical manifestations of the seizures, and in patients with intractable epilepsy, video EEG is indicated to determine whether the patients are surgical candidates or not. The EMU allows a multidisciplinary team of surgeons, neurologists, neurophysiologists, and specialist epilepsy nurses to manage each patient with a customized plan best suited to the individual during the admission, depending on the medication changes and activation procedures. This provides a safe and controlled environment to direct diagnosis and treatment while increasing seizure control and minimizing side effects. The EMU where this study was completed was established in 1998 and consists of 2 adult beds and 1 pediatric bed. A standard pre-admission protocol is performed and informed consent is obtained from each patient prior to admission. EEG is recorded digitally and the data is reviewed each day by the team overseeing the patient. There's an abundance of literature published in the long-term epilepsy monitoring over the past 20 years, covering a broad spectrum of topics in this regard. There's paucity of recently published data focusing on long-term epilepsy monitoring unit patients, the patient population internationally, and to our knowledge, only 1 article has been published in South Africa. There are only 3 comprehensive EMUs in South Africa, serving most of the patient population with suspected epilepsy. Within these facilities, there's an abundance of data, which has a potential to make a remarkable difference in the world of epilepsy. The driving force behind the aims of our study is the irrefutable need for novel research in the field of epilepsy in South Africa. The objectives of this study is to define the characteristics of a South African patient population presenting to an EMU with regards to age and length of stay. Furthermore, trends pertaining to and affecting the admission of an EMU, ultimately highlighting the effectiveness of a long-term epilepsy monitoring unit as a diagnostic tool in patients with suspected epilepsy. This is a retrospective study with quantitative data analysis of previously performed long-term epilepsy monitoring in KZN, South Africa. Patient files were analysed from the 14th of March 2014 and 100 consecutive files were included in the study. There were no files excluded from this study. We defined clinical conclusion categories based on specific criteria. So confirmed epilepsy cases involved both ictal and interictal changes with sound clinical history correlating to a diagnosis of epilepsy. Possible epilepsy category comprised of 2 groups. Firstly, cases with interictal EEG changes and no ictal events, and secondly, cases with interictal EEG changes and psychogenic non-epileptic seizures. The other category consisted of studies with confirmed cardiac or systemic disorder and all other studies which have successfully excluded the diagnosis of epilepsy. The PNES category included confirmed psychogenic non-epileptic cases with a correlating normal EEG. Finally, epilepsy and PNES category involved cases with a combination of both epilepsy and non-epileptic seizures. The epilepsy patients were then further divided into categories, namely focal, generalized, and a combination of focal and generalized based on the International League Against Epilepsy classification. Additional categories in this group were dual pathology, which we defined as a combination of both epileptic and non-epileptic seizures, as well as not applicable, which were the cases that could not be classified as a diagnosis of epilepsy was excluded. So this study complies with the PUPPY Act as well as to the latest edition of the Declaration of Helsinki. Ethics approval was obtained from all relevant committees. When we get to the results section, with regards to age, our youngest patient was 4 months old and our oldest patient was 72 years. The mean age was 22 years with a standard deviation of 17.5. Our population was then divided into less than or equal to 7 years old and more than 7 years old for analysis purposes. In the clinical context, it is common practice to use 7 or 8 years as a maturation cutoff for EEG. The mean length of stay for the sample population was 4.7 days with a standard deviation of 1.98. And when length of stay was audited with respect to age, it was noted that the mean length of stay for the less than or 7 years age group was 3 days, and more than 7 years age group was 5 days. Furthermore, a simple linear model using Pearson correlation was to predict length of stay using age indicated a mild positive correlation between the two variables. So the distribution of referral specialists was as follows. So 51 patients were referred by a neurologist, 32 by a pediatric neurologist, 8 by a pediatrician, by a psychiatrist, 5 by a pediatrician, and 4 by a neurosurgeon. The EEG was confirmed as normal in 29% of the patients and abnormal for 71% of the patients. With respect to clinical conclusion, 49 patients had epilepsy. Possible epilepsy was in 25 patients. 18 patients were classified as in the other category, 11 as psychogenic non-epileptic seizures, and 1 patient with combined epilepsy and psychogenic non-epileptic seizures. Of the total patient sample population, 23% had generalized epilepsy, 16% focal epilepsy, 6% were confirmed with a combination of focal and generalized epilepsy, and 1% with dual pathology. The most pertinent trends relating to the effectiveness of an EMU as a diagnostic tool in patients with suspected epilepsy were explored. So in this table, a correlation of age and EEG results as well as age and epilepsy classification are shown. An abnormal EEG was concluded in 96% of patients less than or equal to 7 years, compared to 64% of patients more than 7 years. Focal epilepsy was evidently more prevalent in the greater than 7 years age group with 69%, compared to less than or equal to 7 years, 31%. However, generalized epilepsy was somewhat similar between the two age groups, 52% and 48% respectively. As expected, a chi-square test of independence indicated a statistically significant correlation between age and both EEG results and epilepsy classification. We hypothesized that the higher prevalence of focal epilepsy in the greater than 7 years population may be correlated with a higher incidence of head injury and stroke in this patient population. Furthermore, in our anecdotal experience at the EMU, a diagnosis of focal epilepsy is very rare in the less than or equal to 7 years group. When exploring the correlation between referring doctor and EEG results in this graph, the most strikingly impressive result is a 94% hit rate of an abnormal EEG from a pediatric neurologist. Furthermore, 75% of the cases referred by the pediatric neurologist were confirmed with epilepsy, in line with published literature. The 100% abnormal EEG referred by the neurosurgeon is expected, as these are always epilepsy surgery workup cases. One of the most striking conclusions underpinning the usefulness of an EMU as a diagnostic tool is the high incidence of abnormal EEG, which was 71%. Secondly, in the clinical conclusion categories, epilepsy has the highest incidence, which was 45%, which fulfills the purpose of an EMU as discussed earlier. The 94% of patients referred by the pediatric neurologist with an abnormal EEG and 75% of patients confirmed with epilepsy reiterates the necessity of an EMU, not just to this referral specialist, but more importantly to the pediatric patients which they manage. It is important to recognize that each patient presenting to the EMU, the goal of admission was to determine whether the patient had epilepsy or not. This question was definitively answered in all 100 cases included in this study. The fact that each patient left the EMU with conclusive diagnostic information further exemplifies the utility of an EMU as a diagnostic tool. In conclusion, based on the trends analyzed in this patient population, long-term epilepsy monitoring is an effective diagnostic tool for the patients with suspected epilepsy. Our findings are concordant with literature that has been reviewed. The significant conclusions drawn in the study need to be interpreted with caution. Results need to be considered as preliminary, and future studies should aim to have a larger sample size to draw sound conclusions about the population of this epilepsy monitoring unit. We recognize several limitations to the study, most strikingly the very small sample size included. Approximately only 3% of the cases from this EMU since conception were included in the study. Gender was also excluded from the study due to the PUPPY Act, which is unfortunate as gender is an instrumental variable in the field of epilepsy. Thank you very much.